The most important thing that we see happening right now is the misuse of opioids. We're seeing it in every segment of the population, and I think we have to get a handle on this. This is a moral imperative for us, and so there are a number of solutions. First of all, I think prevention and making sure that people understand when they get the prescription, how long they should be using it, and the education piece. We need to make sure that our young people are understanding what happens when they use these very powerful drugs. Absolutely looking at the pill mills, and I know that the TMA is also a partner in that to make sure the prescriptions are written appropriately and that when they are written, they're written by people who are in the best interests of their patients, as well as our law enforcement officers. I have a law and order coalition of both DAs and sheriffs that are helping us to take a look at that as well and how we can make sure that we're keeping the community safe. And then finally, making sure when people are ready that we can have a recovery program that best fits their needs and not one size fits all. Continuing to look at those that are effective, that we measure and we know work. And so it's all the way across the board that we've got to look at the prevention, the treatment. And then I think it is really good for us as medical professionals to make sure we're doing everything we can to find ways to safely treat pain without not necessarily using opioids. I have been a nurse now for over 45 years. I still keep my license today. I really believe God made me to be a nurse. I love the nursing profession. I love the medical profession. And I really believe strongly in team approach. And I think the doctor needs to be the leader of that team. I am very concerned about having enough care out in our rural areas. And there is certainly a way that we can use advanced practice practitioners in those areas, but it has to be a team approach where the physician is at the head of that team and that there's a coordination of care. And I think by doing that and making sure that that is the way we do it, that the patients are going to get much more coordinated care and a better care at the end of the day. I see this all the time, that there is definitely a primary care physician shortage, especially in the rural areas. 60% of our state is rural, and I currently serve 19 counties. 50% of my district is rural, and we do have this as an issue, and trying to find a way that we make sure that that very basic care is given to patients in those rural areas is very important. So I think there are a couple of ways we can do that. One is by bringing back state health departments, that we had a pretty good coverage across our state before TennCare, and we're not seeing the kind of quality of care we want. And I will give an example of how this has been taken care of in a part of my own district. In Putnam County, we have a new health department there that is very much used as primary care. There's OB care there. There are two physicians that share, they're retired physicians, they share the time there. We have advanced practice nurses there. And so this model really does work for people who don't have insurance and have an ability to be able to get those services at a cost that they can afford, where it is prorated according to their income. The other way, I think, of handling this is to take a look at the residents and in the GME program, to have that strong so we can help those who want to go into primary care get their residency, help them with the funding on that, with the idea that they're going to be practicing in those rural areas as primary care physicians. So we need to take a look at how we can do this on both sides. I'm not for expanding Medicaid, and part of that is because I know that the dollars in the federal government that fund Medicaid back in the states, especially with the expansion that occurred under the previous administration, those dollars are becoming shorter and shorter, and the states are going to be left without the Medicaid funding that they were once promised. And so I'm not for going down that road where we put something in place and then we have to draw it back. We did that at one point here at the initiation of TennCare, which actually got me into this public policy arena to begin with. So what can we do? I have mentioned that I think we need to have a stronger system where we have more GMEs that get more primary care physicians that can go to the rural areas, but also public health is a big part, whether it's a federally qualified health clinic or whether it is a state health department, that we can find a way to provide those services out in those communities. I want to mention something else that's maybe a little outside of the box on this, is that when we talk about people that are on Medicaid, that are unable to afford those services. Part of that is because they don't have good jobs. They're not in the workforce where they're getting their insurance through their employers or making a good enough salary where they can afford to get health insurance. And so it's a broader perspective. I don't think we just need to look at it through a narrow lens. We need to look at how we can, especially in these rural areas, have economic development, a strong community where there are good jobs. And with those good jobs, they're able to be able to afford their own health care, either through their employer or through private industry where they can afford to purchase those plans for themselves. So education, workforce, all of this go into a piece when we discuss the whole Medicaid issue. The whole issue of balance billing doesn't help either the patient or the physician or our general health care when we have these very narrow networks. First of all, many patients don't really understand when they go to a hospital and they need service about whether that doctor is in their system or not. You come in the emergency room, the doctor that's treating you there, and then maybe ultimately the doctor that cares for you while you're in the hospital, you just believe, because that is the hospital that your insurance company tells you to go to, that you do have coverage. And so they are fooled when they get the additional bill in the mail. They think, well, I did what I was supposed to do. I went to the hospital that is provided for in my insurance plan. And so there's a lot of confusion there. Ultimately, it doesn't help the physician because the physician then many times will not even get paid. And so I think we have to have a good look at this. And I think that the best way to do that is to get a task force together, to get physicians in the room, insurers in the room, the MCOs in the room, and everybody around the table to figure out how do we take care of this issue so no one is surprised at the end of the day and that patients feel comfortable about going to a provider that's within their insurance plan, understanding that they believe it's going to be reimbursed properly. I think that it is imperative that whatever we deal with, whether it is in the home building industry or whether it's in the medical industry or in education, that we have the stakeholders that truly understand how their own profession operates at the table to give us advice on getting the best outcome. And you know, when you do that, not everybody gets their way 100%, but we all feel like at least we have a system we can work within. I will give you an example how I really believe this is important as I deal with this whole opioid issue. I've developed a law and order workforce group, and they are providing me the answers, the sheriffs, the DAs, to tell me what they believe from the law and order side. I'm working with physicians and asking them, what do you think we need to do on the prescribing piece of it? How can we best make sure that we're getting to that point where we're prescribing appropriately, that the patient is being cared for appropriately, but we also are recognizing that there is an overuse and an overprescribing, and how do we handle that? I believe strongly in bringing everyone to the table on the recovery piece. Again, there are multiple ways. Some people need medication-assisted treatment. Other people are good in a 12-step program. I can't know everything, and I want the physicians to be there at the table with me when we make these decisions to ensure that we're going in the proper direction. They're the experts in the area. This episodes of care, I'm hearing more and more from my physician friends that it is not working quite the way that it should. I think it needs to be reevaluated. I had to get a task force together of physicians and other people that understand this, and even have those from Arkansas where the program is working come and talk to us, and let's find a way, if we're going to continue to use it, to make it workable. And physicians are a very large part of helping us to figure that out. I have done that throughout my career, and I think that's just the nurse in me, where I believe that we just need to get everybody around the table, and we'll come out with the best product if we do that. And as already been said, I did that in Congress with the Budget Committee, and people from all the way from one end to the other, and yet we have a product at the end of the day that everybody was proud of. Not everybody got what they wanted, but nowhere in life do we get everything we want. But at least the product that came out was a product we all agreed was a good product for our nation, and we were able to get that done. And so I've built my career around being someone who goes to the stakeholders, gets everybody at the table, and at the end of the day, I believe we get a better product. I think if something's not broken, let's not fix it. I was here in the General Assembly when we did the big medical malpractice tort reform bill. I was a part of that process of looking around the country to say who does it best. And there aren't a whole lot of things that we like to copy California on, but at the time, California was doing a very good job. We used some other states here in the Southeast that were doing a good job, and we modeled that program in 2008. I will say since 2010, when I was elected to Congress, I haven't been intimately involved in its success, but I do understand that we do see a decrease in the number of claims, and we do see a decrease in the medical malpractice insurance, which we had in our state one of the highest in the nation before that landmark legislation was done in 2008. I'm proud of that, and unless they can make it a whole lot better and decrease those claims even more, I think that we leave it where it is. I can compare the maintenance of certification to what we have to do as nurses, and we're not even required here in the state of Tennessee to take a certain number of continuing education credits a year. I know that there are some states that do require that, but I can't imagine having this onerous process that you have to go through every 10 years. I think that it is something that I'd like to look at, and I do want to hear more, maybe even from, I understand there's a task force that has been looking at this and has recommendations. And if we can find a way to not overburden our physicians that are actively practicing and that are in the practice every day, and they keep up with what is required in their own certification. I know different disciplines have different certifications. If they're keeping up with that, I don't know that we should put another burden, another regulation on top of them. Look, overall, I am for getting rid of regulations that don't make sense. We've got far too many of those to begin with, so I would certainly take some recommendations from the TMA about what we can do to make sure that our physicians are not overburdened and that we give them the time to take care of patients. That's really what we want them to do. The regulations that have been put in place on electronic health records have really interfered with the doctor-patient relationship. And not only do I hear that from the physicians, but I hear that from the patients. I hear it from my own family, my own husband, who says now that physicians aren't able to do what they used to do by the bedside, and the more personal interaction that has occurred. I was raised at a time 45 years ago where that interaction was just as important as putting something down on paper. And so I think that we've got to revisit that. You know, when electronic health record idea came to be, the idea was that everybody would be communicating with everyone. So doctors could communicate with the hospitals, and the insurance companies could get information, and the information could flow. Well, what has happened, as in any private industry where people companies want to be able to withhold and not share their information, it's become proprietary. And we in Congress are working on a way to say you cannot just keep proprietary. There's got to be a way to have the interoperability. And that's at the national level, because those are requirements that are put at the federal level and then squashed down to those at the state level. I have said this within my own Ways and Means Committee, and I'm on the health subcommittee there, that we've got to reevaluate what we're doing on the health records. I just want the TMA to know that it is a pleasure for me as a nurse to work with my physicians. I have a great relationship with the doctors, both my personal doctors, the doctors I've worked with in my healthcare career, and now the doctors that I work with in Congress, who, by the way, had to vote me into the Doctors Caucus, and I'm very honored to be there with them. I am the only nurse in Congress right now on the Republican side. And so it is just really an honor for me to be a partner, and I believe it is a partnership. I think that healthcare providers, nurses, physical therapists, occupational therapists, we all need to be together and making sure that we are coordinating care, because that coordination of care is really what gives the best care. And the doctor, being the team leader, makes sense in this circumstance.